Hi, everybody. Welcome to Grand Rounds. We're going to give 1 or 2 more minutes just for everybody to get logged in and the people who are here in person to settle in, and then we'll get started. Okay, we're going to get started. Thanks, everybody, for joining today for Grand Rounds. We'll start with a land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land. All right, it is my pleasure today to introduce Dr. Juan Toro Perez, my colleague and friend. He is an assistant professor in the Division of Neurology here at CHEO. He is a neurologist, pediatric epileptologist, and our clinical neurophysiologist here. He's the medical director of the neurophysiology lab here at CHEO. And he's also a pediatric content committee member for the American Epilepsy Society. So Dr. Toro Perez completed his medical school and neurology training at the Universidad Nacional de Trujillo, Peru. He completed a fellowship in adult epilepsy, EEG, and clinical epilepsy at the Western University in London. And he also completed his pediatric epilepsy fellowship here at CHEO. In addition, he's completed a sleep training at the Children's Hospital of Los Angeles, California. He has a master's degree in clinical and experimental neuroscience and has completed studies in master's and PhD neuroscience. Currently, he's doing a postgrad diploma master's in sleep medicine through the Oxford online program in sleep medicine at the University of Oxford. He was the winner of the Young Investigator Award in 2021 at the American Epilepsy Society annual meeting and the Fellow Best Publication Award in 2024 by the Canadian League Against Epilepsy. In April 2025, his most recent article was recognized as a top viewed article in epileptic disorders. His current research is focused in clinical neurophysiology, drug-resistant epilepsy, sleep disorders, sleep, as well as epilepsy and the ketogenic diet. And today he's going to be talking to us about the pathway of the pre-surgical evaluation in pediatric epilepsy.
Thank you so much, Dr. Muir, colleague and teacher. Well, this was something that I was preparing for our fellows, so we need to understand how is this process, all right? So this is the common way that happen in the situation when we are seeing one patient with seizure. So this is the University of Ottawa. I usually present this slide to let know people how is our hospital. We are part of the university hospital. And this is part of our service. We usually have two fellows. We have nine neurologists, three epileptologists, and also we offer fellowships and six neurophysiology technologies with a different amount of routine EEGs, two EMU, and prolonged and critical care EEGs from newborn up to 18 years. So I don't have any disclosure with this presentation. These are our objectives. So determine the value of the seizure semiology and leading to the journey of the presurgical evaluation, review the process of the presurgical evaluation in pediatrics, and review the proposal for resective or palliative surgery versus neuromodulation. So first of all, we need to start what does mean seizure and what does mean epilepsy. So seizure, as the terminology say here, is a transient occurrence of signs or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. The term transient means that there is a clear onset and a clear offset. So, but what does mean epilepsy? So the definition of epilepsy is at least two unprovoked or reflex seizures 24 hours apart, or one unprovoked seizure, and the probability to get a second one in the context of some structural brain abnormality or some abnormalities in the EEG. And the third definition is the diagnosis of an epileptic syndrome. So I will start here with some videos. This first video is showing a child
Blue turtle.
who is
What did I
breathing
just say?
and during the hyperventilation
Good.
has
Keep
this
going.
EEG pattern, 3 hertz
Black
generalized
cat.
spike and wave. So
Jeremy.
the clinical syndrome for this child is childhood absence epilepsy. Here we have another baby, 6 months old, who came to emergency because starting with some head drops. And during the evening, during the recording, we capture epileptic spasms. This video shows a patient who was having an absence seizure, and then we are seeing evolution to whole body tonic-clonic seizure.
Maybe look 2 points to the left.
Mostly, we are accustomed to see this seizure
Point
type.
off.
So as you see here,
Oh, okay. That's okay.
perfect. Here we have a children who has a right temporal lobe epilepsy. So these children is right now on seizure. So this is a truly focal seizure arising from the right temporal lobe.
Olivia.
While here is the same patient who is having another kind of event that mimics seizure. But you are seeing that there are random movements, and I covered the face because I didn't get the permission to share the face. But the patient is moving the head up and down and moving the head side to side. And then the body is moving around. So this is a non-epileptic seizure, or what is called now functional neurological disorder. So all of them will require our evaluation. So we have the definition of seizure, we have the definition of epilepsy, we need to classify. In the last classification for the International League Against Epilepsy, the things are more easy now. Seizures are classified as focal and no onset, whether focal or generalized, and generalized. And here you are seeing two main things: focal with preserved consciousness or impaired consciousness. In all of them are divided in these types, and after that we can see that some focal seizure could have evolution to the bilateral tonic-clonic activity. So then, as you see here in this part, expanded description, in this new classification, they are giving us the sequence of the motor activity that we are seeing in each patient. So that what is important that is because this information will tell us where are the seizures coming from and will be helpful to create our hypothesis. So there are many definitions, there are many bibliography about semiology. So this is the first step when we are doing evaluation of children with epilepsy. Semiology is the most strong tool that we need to know. So in this sense, I took this classification that was done by Dr. Luders many years ago, and they divide in 5 groups: autonomic seizures, dialeptic seizures, special seizures, motor seizures, and auras. So starting with auras, auras were describing like a sign that happened before the evident clinical activity. However, auras are part of the seizures. So if we have visual auras, we need to think about that some epileptiform activity is starting over the primary visual cortex or in the association visual cortex. For that part, our semiology is important. If it's a elemental visual phenomenon or is a some sophisticated visual phenomenon that we need to clarify. The same for any other auras that we are seeing. All of them are pointing to different part of our brain. If we have autonomic seizures, we need to think about what is an autonomic symptom. So, for example, here, ictal tachycardia or ictal bradycardia. So during seizures, some patients would have rising of the heart ratio and some patients could have bradycardia. So in this sense, they are pointing to different part of the brain. Also vomiting or spitting or hypersalivation. All of them are pointing to different areas of the brain that we need to keep in mind. When we are talking about dialeptic seizures, is what we are talking now consciousness. So dialeptic seizures were defined in based on dialepsis, that is an alteration of the consciousness. And this alteration is characterized by unresponsiveness during the seizure and amnesia of the episode posictally. So then we are seeing different classifications for the International League Against Epilepsy. We were working until early this year with awareness and impaired awareness, but now the new classification substitute awareness terminology for consciousness and mean that the patient should be awake and aware and is defined by the presence of awareness and responsiveness. So that is important that during seizures, we need to evaluate this part. Then we have special seizures like aphasic seizures, hypomotor seizure, akinetic seizures, negative myoclonic seizure, atonic seizures, astatic seizures. So here you will see that there are different motor seizure types. This is one of the seizure types that we see very often, and they are very subtle. Check the shoulders here, please. Did you notice? The patient had jerks. These are myoclonic seizures. Also, we have some specific tonic seizures. When we are seeing tonic seizures, we need to think about that mostly 60, close to 70% of them arise from the frontal lobe, and close to 2% arise from the temporal lobe. And there is one specific semiology in the seizure that is called fencing posture. Uh, when we are seeing these features in seizure, we need to think about the supplementary sensory motor area. That means the mesial part of the frontal lobe and parietal lobe. And also, we can see some, with these kind of seizures, the head could turn to one side, like left or right. And this is the propagation. That means it's starting focal, but evolving to bilateral tonic-clonic. And here we need to figure out about the M2A sign or the 4 sign. This helps us to lateralize because usually in this sense, the extended arm is contralateral to the epileptogenic foci. So this is one sign that tells us where are the seizures coming from. And the other things are clonic seizures that we don't see. There are other specific motor seizures called complex motor seizures. The most common of these is the hypermotor seizures. So this is another video. This patient has frontal lobe epilepsy. Sorry. And we are seeing that he's a little bit restless.
Playing, do.
is able to talk, he's doing some movements, and this patient has hypermotor seizures. So there are also another type of seizure, like an automotor seizure or the elastic seizures that are characterized by laughing. And when we are seeing these seizure types, laughing seizures, we need to think about hypothalamic hamartoma first, but also we need to think about cingulate, anterior cingulate region as a possible epileptogenic foci, or the temporal lobe as well as parietal. Then, going to the most common seizure types is temporal lobe epilepsy. So in temporal lobe epilepsy, it's difficult to recognize in different groups. So this is divided between the first 3 years, between 3 to 6 years, and about 6 years. So during the first 3 years, the semiology could be random, even difficult to lateralize or characterize the seizures. However, this semiology will be more similar to the adult population after the age of 6. So now we are going to talk about this process. Okay, we receive our patient. We need to think about which one really is necessary to refer to one epilepsy center. All right. So in that question, we need to think about: is refractory epilepsy? Is this patient a good candidate for epilepsy surgery? Can we identify these patients? Then, upon we have the answer for these first two questions, we need to follow here in Ontario our Ontario guidelines for presurgical evaluation. And we have two phases: phase 1, phase 2, and different centers are approved for this evaluation. After that, what we usually do is we present our cases to the CHEO seizure conference, and after that, we decide if this patient is candidate for some kind of new procedures or this patient is candidate for stereo EEG. That means record seizures with electrodes inside the brain. And after that, we will have a rediscussion and the conclusions. So when we are considering that one patient has drug-resistant epilepsy, so drug-resistant epilepsy may be defined as a failure of adequate trial to tolerate and appropriate choosing and use anti-epileptic drugs schedules to achieve sustained seizure freedom. Then, what has changed throughout the time? So here, in 2000, 36 of the patients could be drug-resistant epilepsy. So in the new era, with new anti-seizure medications, drug-resistant epilepsy represents 30%. But this is the information that we have from general population. What happened with children? With children happened the same. 20% never achieved seizure control. 10% had seizure control, but eventually became intractable. So here we are seeing the 30%. But also we need to keep in mind that there is another group that could be representing 15 to 20%, where they have progress course and they will be worsening over time. Here, the most common are patients with lesions like a tuberous sclerosis or band heterotopias, or in the context of generalized symptomatic epilepsies, patients with post-anoxia or Lennox-Gastaut syndrome. So, if we identify these patients and we identify that they are drug resistant, who of them should be referred for evaluation? There are clearly patients who has uncontrolled seizure by medication or patients who are disabling, including medication side effects. Another group are patients who has stereotyped or lateralized seizures or the evidence of focality, and or all of them who has an MRI with structural lesion amenable to surgical removal. What are the benefits to refer? if we refer our patient to different epilepsy centers, they will receive a specialized diagnostic and therapeutic approach. That's mean increasing the quality of life of the patients as well as the family. If we identify the dysfunctional network, the etiology, and the type of epilepsy will be one of the other benefits. If the patient has a single lesion, this will lead to early surgical intervention. But when we have complex multifocal lesion, non-lesional epilepsy, additional tests will be required, and also the probability to be seizure-free will be low. When to refer? When the patient has drug resistance, patient preference, multiple parents, therapies, and number of anti-seizure medication, or if the lesion or the lesion is in non-eloquent cortex, we can wait until the age of 5, but usually we have to refer as early as possible. When not to refer? When the patient is not cooperative, or if we identify abuse of alcohol or any other recreational substance. So all of this process that we are doing is with the objective to identify the epileptogenic zone. So epileptogenic zone, by definition, is the area of the cortex that is necessary and sufficient for initiating seizures, and word removal or disconnection is necessary for complete abolition of the seizures. So here, this is the process how we're defining these epileptogenic zones. I will talk in this area. So in this process, we need to identify the epileptogenic zone. And the epileptogenic zone is defined by the presence of other 5 zones. The irritative zone is the area of the cortex that generates interictal spikes. So the epileptiform activity that we see between seizures. What is the most important tool for this? Electroencephalogram, magnetoelectroencephalogram, and electroencephalogram with functional MRI. The seizure onset zone is the area of the cortex that initiate the clinical seizures. How we can identify? But the EEG as well as ictal SPECT. The symptomatogenic zone is the area of the cortex that when is activated, produce the initial ictal symptoms. What is this? Is our initial seizure semiology. The epileptogenic lesion is the macroscopic lesion causative of the epileptic seizures. How we can identify? With the brain MRI. And the functional deficit zone is the area of the cortex that is not functioning normally in the interictal period. How we can assess this? With the neurological examination, the neuropsychological evaluation, the interictal SPECT, and PET. When we discuss all of these zones and identify all of these findings, we can create our epileptogenic zone hypothesis. Also, the second question, is this patient a good candidate for epilepsy surgery? Can we identify these patients? So we have here 2 arrows. If you see this arrow going down, increasing the risk of abnormal neurodevelopment. This is our main worry when we have patients with epilepsy, that they could be or they could have normal neurodevelopment until certain age, and after that we notice that they start to, we are seeing regression. So in this group, we have patients with generalized epilepsy and patients with focal epilepsy. So in the context of surgical workup, which one are the best? The best are in this group. Patients with focal epilepsies, like a mesial temporal lobe epilepsy related with hippocampal sclerosis, patient with Rasmussen syndrome, and patient with focal epilepsies. The other one, as we are seeing, are in the context of generalized. Here are in the context of focal self-limited epilepsies, age-dependent, and also some other group of specific etiologies. But these are the best group. So the best group of patients for success in epilepsy surgery. So which children are candidates for epilepsy surgery? So children with focal cortical dysplasia. So there are 5 groups: focal cortical dysplasia, tuberous sclerosis with single epileptogenic foci, long-term epilepsy-associated tumor like DNETs or gangliogliomas, hypothalamic hamartomas, and multilobar or hemispheric epilepsies secondary for multilobar focal cortical dysplasia, Sturge-Weber syndrome, stroke, Rasmussen, and hippocampal sclerosis. A good tool to review all of these epilepsy syndrome you can find epilepsy diagnosis. Okay, so we have clear, we identify our patient. Now we have to move with the epilepsy monitoring unit. So as I mentioned, this the phase 1 is mostly consistent with capture seizures in the epilepsy monitoring unit. We need to access to a brain MRI in epilepsy protocol and the neuropsychological evaluation. And the phase 2 is after we discuss, new tests could be required. Here we have position emission tomography, magnetic electroencephalography, SPECT, and functional MRI. So with all this process, we can identify 2-level centers for the management of patients. So where we are, you are seeing many etiologies, many resources that we need for each level, and we have the technology that require each level. So where is CHEO? CHEO is in the middle. CHEO has part of this and part of this. Why? We have the EMU. In the level 1, they don't have EMU. In the level 2, they are doing procedures like a ictal SPECT, PECT, MEC. So we are doing ictal SPECT since May 7, 2023. This was our first ictal SPECT. And here we were celebrating last year 10 years of our EMU. Okay. During the EMU, what is important for us, since the epileptologist's point of view, we need to clarify if the seizures are truly focal. And when we are identifying that these are focal, there are some lateralization signs that tell us that seizures are coming from the right or the left hemisphere. And also, with a specific semiology, we are thinking if the seizures are coming from the frontal lobe, temporal lobe, parietal lobe, occipital lobe, or insula. So there are recognized positive motor signs and negative motor signs, and very helpful for us are this focal clonic activity that is ipsilateral to the epileptogenic foci, dystonic limb that is contralateral to the epileptogenic foci, the M2E sign that is contralateral to the epileptogenic foci, and negative motor sign that is common seen in emergency is thought paresis. This is a lateralization sign, contralateral to the paretic side, and ictal paresis or immobile limb that is also contralateral to the epileptogenic foci. Also, there are clear things that we are looking for. Is the positive predictive value for all of other automatisms, postictal nose wiping, ictal speech preservation, postictal cough, and the, for example, unilateral eyelid blinking. All of them, these things that could be for not experienced people unremarkable, for us is very, very important. So if we are seeing only unilateral eye blinking and we have the suspicion of insula, if we find this, it's clearly helpful for us. The postictal nose wiping was not recognized. It's mostly for the adult side, but now we are noticing that it's very strong lateralization side in kids. Then the second point is after the EMU, the neuropsychological assessment. So in the neuropsychological assessment, we are evaluating different areas like a language, academic skill, visual spatial memory, and any other ones. And all of them are important because this is the baseline and will helpful because in the future we will be able to determine how all these other areas were impaired after the procedure. Then in the phase 2, we have position emission tomography. This is we usually use this contrast. Is the FDG is a radiolabeled glucose analog, measure the glucose metabolism. What we are looking for with the position emission tomography is areas of the brain who looks hypometabolic, like here, for example. This patient was reported like a abnormal right temporal lobe, not well defined, the cortical with subcortical junction. So this part of the brain here in PET was recognized as a hypometabolic area. Then we have the single photon emission computed tomography, or SPEC. This study used technetium 99, and what we are seeing here is mostly hyperperfusion. So here, this is a brain MRI who was reported negative, so no clear lesion, and PET is showing hypometabolism in the left temporal lobe, but ictal SPEC is showing hyperperfusion over the left temporal lobe. So here we are identifying the epileptogenic foci is coming from the right temporal lobe. Then we have MEG. By definition, all neurons has magnetic fields. So MEG usually is analyzing with high resolution oils that is called squids, and they help us to evaluate the exact location of the source of the epilepsy-related surgery, epilepsy-related surgery plan for the epilepsy surgery. Here you are seeing all of these areas are the areas that make identify spikes. And functional MRI is another procedure that helps us to lateralize language, since the expressive language as well as the comprehensive language. Okay, upon we have all this information we discussed in the combined seizure conference with CHEO and CKIDS, and that will be the first decision. But if the patient is moving to a stereo EEG, so the procedure is implant electrodes inside the brain, and they are two types of electrodes. One of them are called orthogonal electrodes, and that they are using the horizontal plane, so they are and is represented by these dots. And we have oblique electrodes that is represented in these vertical lines. So these electrodes are implanted based on the hypothesis. So when stereo EEG is recommended, when we have a clear hypothesis with negative brain MRI, with seizure recurrence after epilepsy surgery, when we are thinking that this epileptogenic zone is presumably an extratemporal epileptogenic zone, when there are discordant findings in non-invasive examinations, when the proximity to the presumed epileptogenic zone is close to eloquent cortex. What does mean eloquent cortex? Eloquent cortex means areas that are very important for our life, like the visual cortex, like a language, like a memory in the temporal lobe. When we are talking about language, it's posterior temporal lobe, and also the frontal lobe, and also the primary motor area to move our extremities. These are considered eloquent cortex. So, upon we decide that this patient is candidate, we are going to stereo EEG, we need to determine how we will put our electrodes. In this case, it depends on the epileptogenic zone hypothesis. We need to add electrodes in the area that could be the seizure onset zone, in the surrounding neuronal network propagation region that we are seeing, and also limits. So here, This is one scheme that I received from the Rothschild Center, and they have this scheme to follow. In this blue are following the primary motor cortex. Here is the primary sensory cortex, language, expressive language, comprehensive language, occipital region, and temporal lobe. So, but this is only a huge scheme that we need to keep in mind, and we need to add limits. So, as I mentioned, this is the Tararac template for stereo E planning, and we are using these templates to put our electrodes. So when we have these patients and we complete the stereo EEG evaluation, we have three things that we need to keep in mind. Is this patient, so if you see in pink arrow, we are going from the palliative management to the curative management. And if you see the black arrow here, you are seeing the risk of permanent neurological and cognitive deficit. So that means if we are moving for resection ablation in the different types, could be curative, but also if something fails, the area of the brain that has been removed will not be replaced. If we are doing this connection, here look like a iosotomy or multiple subpial transection, we are in the middle. But if we are doing neuromodulation, it's mostly palliative, but there are more studies in VNS in children. Some of them are going right now in children's respect to deep brain stimulator or RNS. What is the difference with the other one? If we have control of the seizures, we are not having definite cognitive impairment because the part of the brain involved in this function is there. Okay? I will not talk about this. I will say that there are potentially curative and and palliative operation, that this is more field of the neurosurgeon, but this is the indication, the technique, and the outcomes. So, respect to neuromodulation, what do we have? The only device approved for children is VNS. The lastly approved was in 2017, that was moved to children above 4 years old. Before was only about 12 years old. And as you see, DBS and RNS are only approved for people above 18 years old. But right now, they are running some studies to looking for the approval in children. So this is the algorithm given by Epilepsy by Simpson in 2022. If you have patients with focal epilepsy, drug-resistant focal epilepsy, and the patient have to go to neuromodulation, the only option is VNS. It's totally different for patients above 18 years old. When they have two foci, they could move to VNS or DBS, but if they have only one or two foci, they could go to resective ablation or go to RNS. This is the decision algorithm for drug-resistant epilepsy at CHEO Hospital, and they have a patient with pharmaco-resistant epilepsy. If the patient has generalized epilepsy, VNS is the first device. But if the patient has focal, in not localized, they have to move to VNS or DBS. But if the seizure is highly localized with one foci in the eloquent cortex, should go to RNS more than VNS or DBS. If it's in non-eloquent area, have to move to surgery. With two foci, VNS, RNS, or DBS, or more than two foci, VNS or DBS. So, but what are these devices? So, when we are talking about invasive brain stimulator, we are talking about the three devices that were mentioned, but also there are non-invasive brain stimulators that they are under study right now, like a transcranial magnetic stimulation or this other one. And what they are doing, for example, here, I like this image because, for example, this is a patient with temporal lobe epilepsy. You can see if the seizure is focal, why we are seeing some patients who has whole body tonic-clonic seizures is because patients with temporal lobe epilepsy has a neuronal network which propagate over the thalamus. And from the thalamus has multiple connections with the other lobes, and this is propagated. So here we are seeing the propagation of the neuronal network, but all start here in the temporal lobe. So what happens if we are doing resection? If we remove the epileptogenic foci, we are not seeing a stimulation of the thalamus. So the area of propagation of the neuronal network became restored. What happens if we don't we don't resect the lesion, and we are putting a deep brain stimulator in the anterior nucleus of the thalamus? We can do a disruption of this neuronal network, so the area of propagation will be restored too. And what happens if we are doing RNS? RNS give stimulations on and off, on and off, on and off, and also when the patient is having a seizure, stimulate to avoid the seizure. And here, also avoid the propagation to the thalamus, and also the neuronal network is restored. This is mostly the mechanisms. In DBS, we have two areas where the device is implanted. One is the anterior nucleus of the thalamus, that is mostly for focal epilepsies, and the other one is the centromedian nucleus of the thalamus, that is mostly for generalized epilepsies. But there are in the study any other ones. So in RNS, as I mentioned here, this is the device, and there are one generator, two wires, and the patient is like a EEG recording continually during a period of time. And after a while, we have to review all the recording to figure out how many seizures, so mostly the burden seizures. And VNS is a device that we are implanting here at CHEO, and it's like a pacemaker which detects change in the heart ratio related with seizure activity. So when the heart ratio increases with seizures, this device produces discharge trying to stop the seizure. Okay. What time is it? Do we have time? Perfect. I will run quickly with this case. I have 5 minutes, I think. This is an example case that we have had here at CHEO. It's a 14 years old child with unremarkable history, only migraine, but this patient has these things. Starting seizures at the age of 11, the patient has aura, throw-up sensation, and ictally stop talking, head turned to the right, behavioral arrest, manual automatisms, and post-ictally, that was calling the attention, nose rubbing with the right hand. So at the end of the seizure, the patient was rubbing the nose with the right hand. That was the description. And the patient was on 4 anti-seizure medications, unremarkable neurological examination. The EEG showed right temporal slowing as well as right temporal spikes, but also a second image showed left temporal slowing and some left temporal spikes in association. So this is the seizure. I don't know if the seizure lasts longer, but in this part, at the onset of the seizure, the face became a little bit red. There is augmentation of the heart ratio, and then we are seeing activity over the right temporal and bilateral frontal propagation. But the evolution of the seizure here in red is on the right. So you are seeing clearly right temporal. The buildup clearly is right temporal. So we capture the seizure like this. Seizure is a little bit longer, but as you are seeing, the patient was
that's what I thought.
With the left hand, it's a little bit dystonic, and with the right hand, he's trying to do something repetitive. So this is the manual automatism with the right hand, the dystonic posture with the left hand.
So you want to disconnect them, right? Yeah, she can move around. Yeah, sure. How's the IV? You got it? It seems to be inside. Did they got it a second time? It's when? Did they got it in the second time? What do you mean? Because the first one they didn't get in. Oh, they got it the second time? They did, yeah.
Mother noticed.
Is it painful, Ellie?
You notice that he had drooling and he was cleaning them out with both hands. The mother recently noticed that he is on seizure. And you are seeing that the build-up is right, all the time right. Okay, so pay attention the last part. The nurse will move soon. So check the left hand. He's coming. Sorry for that. Now he's aware, able to talk, and he has nose rubbing with the left hand. So we captured 6 seizures, 5 of them with nose rubbing with the right hand and 1 with the left hand. So the neuropsychological evaluation showed CI average. The patient had learning needs and strong verbal compared with visual memory skills. What did show the brain MRI? Showed this area of the brain with diffuse lack of limitation between cortex and subcortex. But also, we noticed in the second brain MRI that the left hippocampus was a little bit bulky. So with these 2 things, the seizure, our immune was very fructiferous for us. The success was because we identified that this patient had ictal speech, that means dominant hemisphere. The patient had right hand automatisms, but also the patient has left dystonic posture. All were pointing to the right temporal lobe. But postictally, the patient had postictal nose rubbing with both hands. That was pointing to bilateral temporal. So this patient had the PET, the same image that I showed, and here showed hypometabolism over the left, but very mild over the right and very mild over the left. If MEG showed bilateral, the language lateralization was left. The patient had different mutations from unknown significance. So when we present this case, we clearly consider the symptomatogenic zone, the seizure onset zone, the irritative zone, the epileptogenic lesion, the functional deficit zone, and our hypothesis was in the conclusion of the epileptogenic zone. The lateralization was a no, could be hemispheric, but the localization was pointing to bilateral temporal right worst. So this patient underwent to stereo EEG planning at CKids, referred to the social work and neurosurgery, and this was the implantation. All of the electrodes were covering bilateral temporal lobe, bilateral mesial frontal regions, and you see all of them were orthogonal, so in the horizontal plane. Here you are seeing the implantation of the electrodes, and here you are seeing the seizures. In red is right, in blue left, and the seizures were arising at the same time. Some of them leading from, the majority of them leading from the right, but few seconds later were starting on the left. So this is in more compressed EEG. You are seeing that starting in the right and spread diffusely to the left hippocampus. So 4 seizures were coming from the right, 1 seizure was coming from the left. So what we can do in this case is bilateral temporal lobe. In this case, this patient fortunately underwent to deep brain stimulator, was implanted in the anterior nucleus of the thalamus. We are seeing here the electrodes. And after implantation, this patient remains seizure-free. right now is only in the Valprox and azlicarbazepine, and he's doing great. So, what are the take homes? Semiology is essential for success in seizure classification and for initiating the presurgical assessment process. We need to be aware of the sign of lateralization with knowing what of them has high predictive positive value. The presurgical assessment is a lengthy and highly individualized process. It depends on the level of the center, resources availability, and patient preference. Stereo EEG implantation requires a good hypothesis of the seizure onset zone. Respect to the neuromodulation, which one is better? We are in the process. But for me, appears that DBS is one of the best. I want to say thank you for all my teachers, mentors from London Adult, London Kids, my group of EEG technologists at CHEO, my friends from different parts of the world, my mentor, Dr. Caraballo, my family, Dr. Zell, and especially to Dr. Muir and Dr. Whiting, who were my program directors during my training. Thank you so much.
Okay, stay up here. We're going to take some questions. Okay, we'll start, I think, in the room. So first, thank you, Dr. Toro Perez. That was an excellent, very detailed overview of how we approach seizures, how we move towards these different therapies, and a lot of the complexities and resources that go into planning for these patients. Okay, so we'll start in the room and see if anybody in the room has any questions for Dr. Toro Perez. Julie.
I know what we used to do. I'm not sure what we're doing now. Is there an age before which we don't care so much about eloquent cortex because the brain is plastic?
Okay, I'm just going to repeat the question for everybody online. So the question in the room is there an age where you don't have to worry so much about whether the brain tissue you're resecting is eloquent cortex, because when they're younger, when children are younger, the brain remains more plastic?
Okay, yes, that is a great question, Julie. So there is a terminology called neuroplasticity. Neuroplasticity is very easy to recover in the first 3 years. So when we are doing, for example, in Rasmussen, because that is the main worry. If we have Rasmussen in the left hemisphere, but you notice that the patient is right-hand dominant, it's important to do as early as possible. Some centers give up to 5-6 years, and the response is good, but as early is done the surgery will be more easy that the other brain assume the function of the other side. In Paris, when I was 2 weeks ago, I noticed one of the neurosurgeons show a video, and the patient was moving the right hand, but with the right hand, but with the left hand was doing some other movement. And then they show us the brain MRI, and the patient had only the right hemisphere. The left hemisphere was removed. Why he was moving the right hand? If we are assuming that was only the right hemisphere, the right side, that was a mirror movement, and the patient recovered, was doing both.
Yeah, that's a great question. And one of the reasons why, I think you probably got the sense from Dr. Toro Perez that this is a resource intensive and long process to get ready for surgery. So this is exactly the reason why we try to start as early as possible to be able to do these surgeries as young as possible. Okay, there's a question here in the chat from Dr. Kovesi. The question is, the vagus nerve is outside of the brain. How does stimulating the vagus nerve affect seizure activity in the brain? It's a good question.
Thank you, Dr. Tom. So, to be honest, until now, there are different hypotheses of possible mechanisms. Until now, is not recognized. The only thing that they know is that vagus nerve, upon the device that detects the heart ratio augmentation, they produce discharge into the brain. I think personally is related with the thalamocortical network. I think this is the pathway how this device works, because vagus nerve, as we know, the center is in the forebrain, but the forebrain has connection with thalamus. So this is the pathway, I am assuming.
Yeah, I would agree with that. We don't know exactly. The current goes from the vagus nerve up into the brain, and then we assume it's disrupting the neuronal networks in the brain that are leading to the seizure. Sometimes in between seizures, but often right during the seizure, we can disrupt it. Okay. Any other questions for Dr. Toro Perez?
Yeah, I know that this is a difficult topic. I was trying to do so didactic, but it's necessary to show our work. So we are planning to expand our emu and start deeply in this field with the most important reason to help our children. Hopefully soon.
Yeah, I would agree with that. Okay, well, if there's no more questions, well, thank you again for an excellent presentation, and hope everybody has a good rest of their day.